Hello again, this is Mr. Holloway. This is Nursing 203, Module A, Congenital Heart Defects. We're looking at defects with increased pulmonary blood flow, or in other words, a left to right shunt. The second in the series is ventricular septal defects. Ventricular septal defects compose about 50% of all congenital heart defects. These defects may be isolated or may be associated with other congenital anomalies, but anyway, they account for about 50% of all the congenital anomalies. The pathophysiology is there is an opening between the two ventricles, between the right and left ventricle, and because of this we see a shunting of blood from the left side to the right side. Just as in the ASD, because of the pressure gradients, the blood moves from an area of higher concentration, which is in the left ventricle, to an area of lower concentration, which is in the right ventricle. Many times with these type issues, we may see left ventricular hypertrophy develop simply because the left ventricle is trying to continue to pump more blood out into the system so that the demands can be met in the systemic circulation. One of the big things that we see, again, we can see pulmonary venous congestion, and a lot of it's going to depend on the size of the left to right shunting, the size of the defect, and again the pulmonary resistance that goes on. We'll take care of that. As we look at these, we really begin to see these children. Again, as we talked about, there's different. We look at the flow. Again, on the left side is the normal heart. Then we look on the right-hand side, and we can see two different types of VSDs. This one basically has a very small. It actually leads more, instead of going through, actually goes more into the vessel itself here, where the more type we see more is actually an opening between the walls, where there's a location of the ventricular septal defect here. What we have is oxygenated blood moving into mixed with unoxygenated blood. So in these cases, what's happening is oxygenated blood is just going back to the lungs and being reoxygenated. No deoxygenated blood is moving out into the systemic circulation. Typically, these children, they're classified as small, moderate to large VSDs. Majority of the children, let me back up. Many of these children have a small VSD, and they can be asymptomatic with that small VSD. What we typically hear as we're doing our physical exam on these children is we hear a systolic murmur on these children. And the larger the defect, the louder the murmur, the greater the intensity of the murmur that we may hear. 75 to 80% of these children with a small VSD require no treatment, as they will close spontaneously. Some of these children who are asymptomatic without any hemodynamic type problems actually do not require surgery. It's thought that the risk of surgery does not outweigh the risk of surgery is greater than the risk of not doing surgery. That's what I want to say. So it's more risky to do the surgery than for the child to live with that small VSD. Now, if that VSD is large enough and this child is having significant symptoms, which typically are related to congestive heart failure, then we need to look at doing surgery on these children. Typically with these large VSDs, we're going to see the CHF, the tachypnea, the diaphoresis. These children are going to fatigue very easily. They may tire before they finish feeding. Remember when we talked about in the work of breathing uses up so many calories, and these children also just don't have the energy to feed properly. So this child may be beginning to look like failure to thrive. So we're looking for all of these type symptomology with these patients. So if we're seeing those, we're seeing this child who fatigues easily, tires before eating, not eating well, a failure to thrive with a loud holosystolic murmur, we can pretty much suspect a ventricular septal defect on these children. Diagnostically, of course, the echocardiogram is going to confirm that VSD and help with looking at the size. These children may go for a cardiac catheterization to really give a better look at how large that VSD is. A chest x-ray may be done to see if there's any cardiomyopathy, enlargement of the left ventricle, or if there's any fluid buildup back into the lungs because of this problem. So all of those can be done. Many times these children may be put on prophylactic antibiotics for 6 months to prevent bacterial endocarditis with these children. So it may be something that we will see. Treatment, basically, again, we talked about with the small VSDs, if they're asymptomatic, 75 to 80% will close spontaneously. They are closing some smaller ones now with basically interventional cardiac catheterizations, or they may be left alone. It's just a risk versus benefits type process as they look at the child. And that'll be a discussion that will go between the cardiologist and the parents to look at the risk. Now, if it's a large VSD and these children are having significant type problems, then we're going to try to close that VSD. Typically, that's done somewhere between 3 and 12 months of age, and that's done to prevent the development of pulmonary vascular disease in these children. It's indicated even earlier in small infants who are having that failure to thrive we talked about. The defect is typically closed with suturing or with a synthetic material while this child is on cardiopulmonary bypass machine. Has to be done so they can slow the heart down so you can get in there and sew that area in place. So these children are going through significant surgeries. I mean, we're looking at actually doing a medial sternotomy and putting these children on bypass grafts. So you can see why, if that's a small VSD and they're asymptomatic, why they're going to leave it alone and not do that. Surgical mortality is less than 5% when performed in the first year of life. Those who have surgery after 2 years of age may have more residual problems with arrhythmias and depressed cardiac function and some pulmonary hypertension. But it's hard to predict who's going to have what. But typically, they're going to try to stabilize if they have a large VSD. They're going to try to stabilize them medically for the first few months. That may mean inotropes, diuretics, doing some sort of vascular SVR reduction, PVR reductions for those. May mean that we need to look at the formula on these children, especially if they're failure to thrive, increasing that caloric intake, and then looking at maybe NG tubes or JG tubes for these infants who are tiring easily, so that we can do those type things for them. Again, this VSD is the largest is the most common of the congenital defects. If it is a large murmur, it has to be treated surgically, and there are risks with that as these children go onto cardiopulmonary bypass machines to do this. So some of the nursing type problems that you're going to see is decreased cardiac output. You may see impaired gas exchange. Of course, with the surgery, we're going to see all the things that go along with the surgery process. These children are going to probably have a mediastinal tube, 2 chest tubes, all of that going in place as they go forward. It's really a very difficult surgery for these children. Some of the postoperative complications that can go along with this is with any open heart surgery. They can have atrioventricular dysrhythmias. They can go into complete heart block. Again, sometimes that is temporary because of the swelling that goes on. But depending on exactly where that VSD is and where they have to cut to get in there, it may make a big difference. You could sever some of the electrical pathway of the heart and child end up with complete heart block and then require a pacemaker. You may not get it closed completely. You may have a little bit of residual shunt, or you can have leaking at the repair. Typically, if there's some leaking at the repair site, they'll go back with a cardiac cath, interventional cardiology, and see if they can fix that leak. outcomes with these children. These children with a small VSD typically live a normal life, have normal health. I do have to monitor them for risk of bacterial endocarditis. They may be on antibiotics for the rest of their life. The large VSDs need to be repaired in the first 2 years of life. Many times lead a normal, healthy life. For those who don't have surgery, basically we're looking at heart failure, increased risk of endocarditis. Again, we don't see that much in the United States, but you may see that in some third world countries. This is all I have on VSDs, ventricular septal defects. This completes the second portion of the defects with increased pulmonary blood flow. Thank you.